My name is Sierra Lockstadt, and today I'm going to be talking to you about a previously undocumented presentation of CDK4/6 inhibitor-induced dermatitis. Our learning objective is to recognize that non-life-threatening dermatological adverse reactions to precision therapies can result in change of treatment and compromise survival outcomes. Our case is a 55-year-old woman with past medical history significant for ER-positive, PR-negative, HER2-positive, metastatic intraductal breast carcinoma. She came to the ED with chief complaint of generalized erythema, dryness, pruritus, and hyperpigmentation of her torso and extremities. She had previously been treated with anastrozole and palliative radiation for spinal metastasis. She was later started on the CDK4/6 inhibitor palbociclib. She initially tolerated this therapy well, with response evidenced in tumor markers, imaging, and her clinical condition. However, over the course of 11 months and at least 14 cycles of palbociclib, she noted skin changes characterized by severe irritation and hyperpigmentation. Physical exam was significant for rash on the extremities and torso with diffuse erythematous lichenified and hyperpigmented coalescing patches with excoriation. She also had some superficial wounds. You can see the rash here in figures 1 through 3. In the ED, dermatology was consulted and discharged her with prescriptions for cetirizine, diphenhydramine, triamcinolone, and hydrocortisone creams for the rash. She was given mupirocin ointment for her open wounds. She was referred to outpatient dermatology. While she was waiting for that appointment, she saw her oncologist, and it was decided to change her from palbociclib to a different CDK4/6 inhibitor, abemaciclib. We wanted to see if the adverse skin reaction was specific to the agent versus the entire drug class. Later, in the dermatology clinic, a punch biopsy revealed eczematoid dermatitis, likely secondary to an adverse eczematoid drug reaction, presumably from the CDK4/6 inhibitors. She soon requested to stop all CDK4/6 inhibitors as she had stable bone-only disease and recurrence of cutaneous symptoms despite changing drugs within the same class. She was continued on single-agent aromatase inhibitor and reported improvement in her dermatological conditions despite no change in her skin hyperpigmentation. She did progress based on imaging, and she was started on capecitabine. So there are now 3 FDA-approved CDK4/6 inhibitors since this class was first approved in 2015. While some of the most common adverse reactions with CDK4/6 inhibitors were neutropenia and leukopenia, the full range of less common reactions, such as cutaneous manifestations, remains poorly characterized or reported because of the relatively recent availability of these agents on the consumer market. Eczematoid dermatitis has been reported in patients treated with combination therapy, including palbociclib. At least 10 other reports of skin reactions, however, not the same one that was seen here, were observed with palbociclib and abemaciclib. However, this reaction has never been seen in palbociclib in combination with endocrine therapy. In similar cases, the average time between drug initiation and report of a cutaneous reaction was almost 7 months. However, our patient persisted almost 11 months, which was longer than the average. Some of the previously documented skin reactions were serious and life-threatening, including Stevens-Johnson's and toxic epidermal necrolysis, suggesting that physical exam and screening for skin reactions can benefit for prompt identification of potentially fatal toxicities related to chemotherapy. We hypothesized that the mechanism of eczematoid dermatosis and CDK4/6 inhibitors can be similar to that seen in actinic keratosis, which develops from mutations in P16. These mutations also prevent an activation of CDK4/6, resulting in carcinogenesis. In conclusion, we present here the first case to our knowledge of eczematoid dermatitis resulting from CDK4/6 inhibitors. While the dermatitis seen in the reported patient was not life-threatening, toxicities can result in either delay of treatment, as the drug can be held temporarily due to severity of symptoms, reduction in dose, or complete discontinuation. In our case, we exchanged from one medication to another one within the same class, however, it resulted in minimal improvement. The patient eventually elected to discontinue all CDK4/6 inhibitors due to her adverse reaction. Sadly, this resulted in progression of her disease.